George, is the huddle room working out all right?
What?
The huddle room.
Yeah, Gary's not very far away, actually, in real space.
Gary, we thought it was a prison cell.
That's why we put George in there.
That's where they keep the state medical director.
Does the door lock on the outside and water start filling from the floor up?
Exactly. They let me out for meetings and things like that, but that's it.
All righty. Well, I'm going to turn my camera off.
So Kathy, it looks like we're up to noon. Are we going to, do we want to start now?
Yeah, I think we're going to go ahead and start. Just a reminder to everyone, the sessions today are being recorded, or the session today is being recorded. This is one of those that I've been looking forward to all week. We're joined today by our colleagues to talk about, it was actually intended as kind of a thinking out of the box sort of thing. Everybody's been reinventing themselves over the past several months. Hopefully you were able to join our remote inspections and surveys presentations yesterday. Obviously a lot of new data coming out of NASEMSO. We have been trying to keep we've been trying to keep the website as up to date as possible. We do have a new YouTube channel, and we're troubleshooting getting the videos, links to videos to those of you that can't access YouTube from your state computers. That being said, we are sharing PowerPoints on the website and making information from the panelists available to you to access. So without further adu, I'm pleased to welcome all of you and welcome our friends Doug and Kevin and George to talk to us today about telehealth, alternate care facilities, EMS provider roles, community paramedicine, non-transport, anything that might be on their mind. And at the end of the session, we'll try again to open the microphone so that you can interact with the panelists. So without further ado, Kevin, I'm throwing it over to you, and thanks again to all for participating.
Thanks, Kathy. Well, again, I'm Kevin McGinnis. If you don't know me, I'm program manager for National Association of State EMS officials in a number of different areas, but in particular, community paramedicine, rural EMS, public safety communications, and so on and so forth. To my, whatever you may see, left or right, Dr. George Lindbeck, who is the state medical director, or I should say the Commonwealth medical director in Virginia, as well as the chair of the NASEMSO Medical Directors Council. And on my other side is Dr. Doug Kupas, who is the Commonwealth, wow, I'm surrounded by Commonwealths. Poor guys up here in Maine, we just got a state. Commonwealth of Pennsylvania Medical Director. But in tackling, in the spirit of reinventing EMS and kind of thinking outside the box, I would sort of underscore that none of us really is representing anybody here today, whether it's their Commonwealth, state, or council. These are thoughts from these guys, and we're going to kind of leave it at that. We're going to tackle a number of issues that we thought would be appropriate and kind of reshape them into how they might look in the future, going down one road or another, probably not without some controversy in many of them. Yes, indeed.
Okay, so hopefully right now you are seeing a title slide that says EMS Reimagined. So, you know, this whole conference was NASEMSO Reimagined. I think that this is very much EMS Reimagined. And, you know, I will tell you by way of introduction that this is actually my 20th year. In April, I hit 20 years as the Commonwealth EMS Medical Director for Pennsylvania. And it's also my 40th year as an EMS provider. And so I have been, you know, doing some talking around the state saying that, you know, hindsight is 20/40, and trying to give some lessons learned from those 20 and 40 years, but also what I see as predictions for the future. And that's really what I want to concentrate on with this, is what are the predictions for the future. Even before COVID, I was saying that I think that what is going on right now in EMS is the most exciting and maybe formative thing that has occurred basically since the 1973 EMS Systems Act, as far as the impact that it will have on EMS. I think COVID can be looked at in two ways. You know, COVID certainly has interrupted a lot of what we were doing in moving forward with all of the very exciting things that are going on right now, like ET3. But I think on the other hand, COVID has become a catalyst to push some things forward at a rate faster than they were moving anyway. So it may ultimately turn out that things like ET3 get run right over by an interest in just going beyond the pilot and getting it mainstream because of some things that have happened with COVID. So we want to talk a little bit about how EMS integrates with health systems, MIH, the professionalism of EMS, and everything that's going forward at this point. Yeah, I think that for some time now, and probably many of you have seen these efforts, you know, this article goes back to 2015. States strive to keep Medicaid patients out of the emergency department from the Pew Health Group. And, you know, I have seen across the country and in my state and locally, these ideas of, you know, the emergency departments are the bad guys of healthcare now. And linked to that, EMS gets the overflow from that. You know, there are lots of initiatives that are going on right now to try to keep patients out of emergency departments and out of hospitals. You know, health insurers, I think, all went to the same seminar where they were told the goal is to keep your patients out of those expensive EDs and hospitals. And I will suggest that there really is a better goal. The better goal is keep people well at home. And, you know, I'm talking to you as one of your friends, as a state EMS medical director and longtime NASEMSO member. But I have to tell you that I do try to make sure that my hats stay separate. And I will fully disclose that much of what I'm going to say today is from a smaller microcosm of observation through my day job, so to speak. My job with my health system is the director of MIH. And this is one of our very veteran MIH providers here taking a staged photo because I know her patient's sleeve should have been rolled up to take that blood pressure, but this was a stock photo for staging. But our goal really, as people have told us, you know, we need to keep people out of the ED, my pushback is no, we have to keep people well at home. And when we can, that's great. And when we can't, the ED serves a very important purpose. I want to tell you a little story from 1 week ago. A week ago last Tuesday, I was actually working from home and doing some work, just, you know, sort of administrative work, and a call went out in a neighboring county very close to my home, about 5 miles away, for one of our EMS BLS ambulances to go and pick up a patient. The dispatch information was for cellulitis. The patient believes it is worsening. Now, in many EMS systems, that would have been a lights and siren kind of response. In our system, a BLS crew took the call, the ambulance that you see right there. But as soon as they got on the air, they asked for a fire department to be dispatched for a lift assist because they've been to this house before and they knew that the patient was, you know, fairly heavy. So I actually contacted the crew. I said, you know what, I will meet you at the scene. Cancel the fire department. I will meet you at the scene and we're going to try to do a treat in place. So I went out to the scene and found a woman who had had an amputee, rather heavy, who had had swelling and some signs of cellulitis in her good remaining leg for 10 days. It had not changed a bit in the last 2 days, 3 days, 7 days. It had been the same for 10 days, but it clearly had some signs of cellulitis. It was tender, it was red, a little bit indurated. And she was calling the ambulance to go to the hospital. And the traditional thing would be, you know, you call, we haul, that's all. They'd take her to the emergency department. She'd spend some time there. I assessed her leg. She wasn't febrile. She was fine. and this had been going on for 10 days. I contacted our MIH unit, which is the vehicle that you see behind there. They came over, we administered IV antibiotics to her. She was very amenable to this. She actually loved staying at home and not going to the ED. We administered IV antibiotics, set up a plan for MIH to come back the next day and give another dose. And I contacted her PCP office, who called in oral antibiotics that her sister picked up that afternoon and she started on, and they arranged for an office visit 3 days later. Totally what this patient needed. She didn't need to go to the emergency department, and this is the EMS that we really need to be doing in the future, because our current way of handling these kinds of patients just isn't right, and they happen every single day in every system. So you heard it here first. Since 2019, I have been saying this, but I want to get credit for this quote. In the future, every EMS provider will be viewed as an MIH provider, or as having a role in MIH. I think we can't view MIH as a separate entity. We need to view every single EMS provider as having the possibility of doing some parts of MIH. And sometimes you need a more advanced unit with very experienced people to do IV diuresis on a CHF exacerbation. And other times, you know, an EMT can participate in this. You know, you all know better than anybody the history of EMS revenue and the history with CMS. You know, EMS is viewed as a transport supplier, not a healthcare provider. And we're finally in 2020 seeing a shift in that. Little steps, but I think they're going to lead to a much bigger step. And we need to get our EMS systems thinking of themselves as healthcare providers and part of the healthcare system, rather than as transport suppliers that just bill for their care. This is, I think, no more or no less important in the rural areas. You know, we have rural areas of the country where they're losing their hospitals, they're losing their doctors. They still have EMS agencies that are struggling. And honestly, those, in my mind, those EMS agencies are prime to pick up doing a lot of the healthcare, like I just described, in their area, actually become more busy and more professionally recognized by the healthcare system, more integrated to the healthcare system, and then likewise, they need to be compensated in that same way. Because as we lose more expensive hospitals and doctors, EMS is primed for taking up some of that. You know, Brendan Carr did this study that basically shows, you know, how far people are from access to hospitals. And if you look at tertiary care hospitals in the map on the right, if the map is showing yellow, those individuals are more than 90 minutes from a tertiary care hospital. The map on the left is just, you know, from a simple critical access hospital, and you can see how many places are even 90 minutes from the most simple hospitals. So, you know, EMS really is primed for this. Here's a local example for me. So our health system is part of the Keystone ACO, the Accountable Care Organization set up under the Obamacare type things. And, you know, politics aside, this Accountable Care Organization has been saving money for Medicaid or Medicare constituents. They're set up in sort of geographical regions. And the MIH providers that I oversee right now are functioning in almost 20 counties in Pennsylvania. Basically, everywhere you see in green and yellow are the MIH units that I oversee as part of my day job. You know, I think we in EMS have to figure out what our value is. I almost put a picture in here of the standard EMS provider that you see these days. If they're wearing a vest, usually it's a black vest with pockets. They're very police looking. Their uniforms are police looking. And, you know, I think there's this great excitement around being tactical. Even wearing black gloves to assess patients instead of, you know, the more standard medical colors for gloves, because we're tactical, right? Well, I think we need to start figuring out how we're medical, because the vast majority of what we do is provide healthcare. We do some public safety, we do some public health, and those are very important things. And we also have to be prepared for active shooters, et cetera. But our EMS providers will run into a lot more patients with some worsening cellulitis than they will an active shooter issue. And, you know, we in some ways are breeding our providers to be thinking about the tactical things, but not being like medical providers in our healthcare system, which is really where we provide our most value. I like this next slide because I took this from Brent Asplin, who was the chairman of emergency medicine at Mayo many years ago. This concept probably comes from seeing him talk about 15 years ago. And he put all of healthcare into three big buckets. We have chronic care and wellness, you know, the primary care kind of stuff. We have acute and episodic care when somebody has a trauma or a heart attack or whatever. And we have palliative care and end of life care. And, you know, those are all big buckets that EMS, especially MIH, can actually have some value to. And this quote in the middle always interests me. EMS of the future will be community-based health management, which is fully integrated with the overall healthcare system. In my personal health system, that is what we are trying to do. I think there are many places trying to do that now. But, you know, the real kicker is many of you that are veteran at this recognize this was from the EMS agenda for the future that NHTSA put out in 1996. And we are certainly not there. This is a document to sort of sum up and show the model that Geisinger EMS is using for our MIH and EMS. You can see that the traditional 911 transport's up there in the right-hand box, but you can see that, you know, having various differences in risk, cost savings, and system complexity, we are doing 911 treat in place. We're doing SNF treat in place programs. We're doing post-ED care follow-up programs, post-admission care follow-ups. We're part of a system called Geisinger at Home, where they have a whole cadre of nurses, pharmacists, et cetera, that do home visits for the most sick of the health plan patients, hospital at home programs, heart failure and COPD home care, and preventative care like immunizations and things. And, you know, a lot of that is overseen by me and our ED telemedicine program with a system triage officer that's an emergency physician or other EMS medical directors, but we integrate with the Geisinger at Home physicians, the e-hospitalists, cardiologists, pulmonary physicians, and primary care physicians. So another, you heard it here first, I believe that in the near future, EMS agencies that embrace patient-centered healthcare that is integrated with regional health systems will provide 20% traditional 911 response and transport and 80% home-centered care. And you might think that is just a startling prediction, but I will tell you that I think the fire departments of the past would never have expected that they were going to be doing 80 or 90% of their work doing EMS calls and only, you know, 10% or so of fire calls. And the fire departments that did not embrace EMS have struggled, I think, with that. And the ones that have truly embraced EMS, you know, EMS is basically driving what their service does. I think this very same thing can happen with EMS. If we really look at which patients need to be transported to the hospitals and what we can do for people at home, not only that call 911, but proactively, it certainly could be an 80-20 mix of doing home-centered care versus 911 transport to the ED. So, you know, this, this next slide basically just shows the rollout of ET3. You know, not very often, I don't think, in the history of the United States that a Secretary of Health and Human Services stood in front of an ambulance for anything. So it was really a big deal that ET3 is rolling out. I don't want to put a lot of time on ET3 because I think that, as I said, a lot of the ET3 goals are coming to fruition and being bypassed by things with COVID, like telehealth in ambulances and that sort of thing, which I'll talk a little bit more about later. The history of revenue for healthcare, you know, basically is that we have pretty quickly gone from largely fee-for-service to largely alternative payment models based on value. Now, EMS has not gotten to that point yet. We're not really to pay for value, but I think it's natural that it will be coming. I think before pay for performance usually comes pay for measurement, and I'm going to tell you about a little thing that's been going on for that. Let me give you one simple example. You know, EP3 suggested that they might be able to save $540 million in costs in emergency department and hospital care by having paying EMS to do alternative destinations and treat at home. Well, here's another paradigm here. There's the scoop and run version of cardiac arrests versus the what I refuse to call stay and play. I call it treat on the X. This is from a little study that we did that showed that agencies that had low field termination rates versus high field termination rates, you can see that the EMS agencies in the country in the CARES database that had the highest rates of doing field terminations, treating the patient, but then stopping and leaving them as a terminated resuscitation if it's futile, actually had the much higher rates of ROSC, survival to discharge, and favorable neurologic function than the agencies that did very little field termination and transported everybody to the emergency department. I think that's pretty interesting. So our current state is that we pay an ALS fee if we treat and transport a cardiac arrest to the hospital with an ALS crew. And as soon as that patient hits the door, there's an additional about $4,000 ED fee, even if they only do 5 minutes of CPR and say, oh, this is futile, we're stopping. The fact that they did CPR, called a code team, and had their physician and their hospital expenses, it's over $5,000 or $4,000. In many cases, if they do a bit more, it could be up to $10,000 fee for these people. And if they do a field termination, some EMS or some Medicare regions will pay a BLS fee. So what we're proposing, and we're actually working with Admiral Giroir. Many of you might recognize Admiral Giroir as the Assistant Secretary of Health who's been sort of running the testing things in the country, but he's actually a pediatric intensivist, and very interested in cardiac arrest care. And we're actually looking at a proposal that would actually fund CARES data nationally across all states. EMS providers would be paid an ALS fee, and if you send 2 ambulances, possibly 2 ALS fees, if you treat and then do a field termination on a patient at home. And in other words, you're going to get paid if you take the patient to the hospital, but you're also going to get paid if you treat these patients and do a field termination. And it's a win-win all the way around. The ambulances get paid, the hospitals aren't disrupted by cardiac arrests that come in that have no chance of survival but are very time consuming for the physicians and that sort of thing. And the payer wins because it's much cheaper to pay EMS to treat them at the scene if they are a futile case than it is to take them to the hospital and have that $4,000+ fee. So what do we need for this vision that I've outlined? I think a lot of things are in place. A lot of people are forward thinking about this. I think we need a couple other important things. One is nomenclature, and 2 is EMS being a profession. Many of you may have followed that there was some discussion. NHTSA actually put together a group to talk about nomenclature. We have to get past the fact that what I'm describing is not really EMS, because that lady that had the cellulitis for 10 days, it's hard to call that an emergency. And EMS, EMT, paramedic, first responders, etc., get it's no surprise that, when people in public office talk about us, they often talk about, fire, police, and emergency responders, fire, police, and whatever, fire, police, period, and leave out EMS. We need a name. We could talk for days about what that name is. I personally think that what we are doing is paramedicine, like many other countries call it. And I think all of our levels of providers should be some level of paramedic, just like an LPN and an RN that has a master's degree are all nurses. George is going to talk a little bit more about this, but I do think that, we have to get to the point where our EMS providers are looked at like a respiratory therapist or a physical therapist or other of the traditional professionals within healthcare And we need to be viewed as part of that healthcare team, not just the team that brings the patient to the hospital. And one of our MIH providers here is looking into the back of our vehicle, which is a standard ALS squad, except it has a centrifuge there because they process a lot of blood, and it has a refrigerator for things like our flu shots and that sort of thing. And we also need to pay our providers as we recognize them. We need to pay them commensurate to what other similar healthcare professionals get. You know, after all, we make house calls. We are set up to do this type of work that is very much needed, and we need to get there. So here's my EMS Reimagined. We need to pay for services, not transport. We need to be integrated with health systems because that is the driver of all of this. All EMS practitioners have a role in MIH. We have to have engaged medical direction. It's critical to this. This is paramedicine, or whatever nomenclature we decide is best, but our current nomenclature is confusing everybody and we don't have a real voice. Paramedicine practitioners must be on par with similar healthcare professionals. Paramedicine can improve increasing healthcare gaps in rural areas. And you know, we make house calls and we can keep people well at home. So thanks for the attention, and I look forward to the rest of our conversations here.
All right, so are people seeing the future of EMS screen now?
Yeah, we can see it, George.
Okay, good. Andy, I think you can go ahead and move to the next slide then. Kevin is going to make some comments later about communication and telemedicine. And that first slide showed one of my providers who is doing a neurologic exam in the back of the ambulance and having real-time communication with a stroke neurologist on the other end of the system there, which I think is a pretty neat idea. One issue that's caught my attention lately over the last year or so has been interfacility transport. So in the history of EMS, we've sort of focused more on traditional 911 response. And this is Roy and Johnny back from the TV series back in the 70s. And we've always sort of focused on EMS as representing pre-hospital care. Next slide, Hannah. But as we've developed all these regionalized systems of care, these spoken hub models, we put an awful lot of attention into the pre-hospital end of things and destination decision making and ultimate destinations based on the patient's acuity. But we really haven't, I think, paid enough attention to what happens in between that first receiving institution and then where the patient gets transferred to their definitive care, if you will. Next slide. In Virginia, about 60% of our air medical transports are interfacility, and at least 40% of ground transports are interfacility. So a lot of what we do in EMS is relatively invisible. We certainly pay attention to it from the state point of view. These are all licensed and inspected EMS agencies. One of the things that helped me focus on this personally was I've spent about half my career working in community emergency medicine and about half in academic emergency medicine. So I've been on both sides of this. I've been on the sending side as well as the receiving side. And particularly once I returned to the University of Virginia, it made me very aware that there's a lot of variability out there in how patients get to the tertiary care referral center from their initial destination. Next slide, Hannah. And again, this spoken hub. So we've got this, and I use stroke as the example here, but we could be talking about trauma patients. We could be talking about STEMI patients. We could be talking about pediatric acute or critical care. The ideas are sort of the same. You get this patient with a time critical injury or illness. They end up at an initial center, and then they get transferred to the referral center, the comprehensive stroke center, the level 1 trauma center, et cetera, et cetera. And we put a lot of effort into developing these spoken hub models and developing regionalized care for these very resource intensive illnesses and injuries. Next slide. We talk about bypass. So is it appropriate at times to bypass the closest facility? And the answer to that is yes. It works when there are facilities with higher levels of care that are fairly close together. But once you get very long transport times, particularly in the order of 60 minutes or longer, then the benefits of that bypass start to be mitigated, start to be lessened. And then a lot of time can pass before that patient can make it out the door of the first facility and get on the road to the definitive care facility. And I refer to that as patients getting marooned. So it's not that the receiving physician or that first institution doesn't know what to do. It doesn't mean that they don't know what they want to accomplish, but their ability to effect that transfer may be impaired by the availability of appropriate transfer mechanisms. I ran into this when I worked in a freestanding emergency department. We would have patients who drove in or walked in that were really sick, and we wanted to get them back to the main hospital, but they sometimes would be stuck there for hours waiting for an appropriate transfer modality to be available. Next slide. And the technology has really changed. We've got these transport ventilators that require quite a bit of knowledge. You don't just hook somebody up and they push some air in and let them exhale and then repeat every few seconds. There's a lot of knowledge that goes into that. Balloon pumps, Hannah, you can click again and some other pictures will come up. Impella devices are becoming more common now. We have ongoing drips now of these patients that are transferred. Propofol, vasopressor drips, blood control drips, blood pressure control drips like nicardipine. And finally, this is a picture of an ECMO pump. We are actually getting more transfers now with patients who have been started on ECMO. And this is way outside traditional 911 pre-hospital care. And my argument is not that it isn't within what we can do in paramedicine with or without supplemented crews, but that it's beyond what we run into in our basic certification levels. Next slide. So who does these transports? Well, these are typically done by EMS providers. So one of my observations is that this really lies in our world as EMS providers. They may be supplemented by other providers, nurses, respiratory therapists, and perfusionists, but many of these critical care interfacility transports are done by paramedics, in Virginia, intermediate level providers, variety of agencies involved. Of course, we're all familiar with air medical agencies. Some are hospital-based, some are commercial, and occasionally local 911 agencies have to sort of pinch hit, which is generally less than desirable when you've got a critical care transport that needs to be done. But they may be pushed into service if they're the only resource available to effect that transfer. Next slide. What about transferring physicians? What I realized was, particularly in community practice, and Doug would probably second this, even among card-carrying emergency physicians, so residency trained, board-certified emergency physicians, how many of those docs are interested in and familiar with EMS systems? And I would say less than 5%. So a lot of the physicians that are making these transfers really don't have a good feeling for what the system can provide, what the capabilities are, what the resources are. And keep in mind that a lot of these transfers don't come from the emergency department. They come from labor and delivery. They come from pediatric intensive care units, medical intensive care units, coronary care units, where the physicians are probably even less familiar with what's going to happen when that patient gets on the road for their transfer. Are the resources available? Are they appropriate? Timeliness is important. We've set these time windows for optimal outcomes from stroke and STEMI. And if there's a long delay in getting a capable, appropriate resource to transfer the patient, we're going to miss those optimum time windows. Is anything acceptable in a pinch? Our answer should be no, but I think what really happens in practice is if you can't find a good resource to get the patient out your door and onto the road, are you willing to accept anything that's available? And my feeling is that that happens a little more often than we realize or that we would desire. Next slide. Air medical services have certainly filled this gap and provide a really important part of our system. They generally provide very high quality care. They're well supported by their sponsoring institutions, but they're also a limited resource. They're not always available, and they're not always the most appropriate resource. We would like to have a resource that is available, capable, and able to do a ground transport without the expense and, to some extent, the safety risk of air medical resources. We had a big blow up in Virginia, and there's been a lot of national press about the cost of air medical transports, which can be several times what the cost of a similar ground critical care transport would be, but often we don't have that resource available, and the air medical program becomes the only program available. Next slide. So where do we go from here? Again, I would argue that EMS owns this. These transports are largely performed by licensed EMS agencies with licensed or certified EMS providers. This is part of what we do. Again, it's not the traditional 911 pre-hospital care, but it is a large part of what we do in terms of patient care. The interfacility portion of the patient's care needs to be an integral part of the plan. And what I have found is that when some of these spoke and hub systems get designed, the tertiary care hospitals, the quaternary care hospitals, if you will, want these patients. The institutions that receive them first want to be able to transfer them, but relatively little planning is put into how that transfer is going to be affected. And there needs to be shared responsibility between the referring and receiving hospitals. These transfers are inevitable. They're going to happen. The patients are going to be sick. We need to make sure that we've got a resource available to make that happen in a high quality way. Next slide. Is it time for nationally accepted certification for critical care? There's good training out there, but it's not a standardized certification. In Virginia, and Hannah, you can click once more. In Virginia, we value that training, but it doesn't necessarily expand your scope of practice as a paramedic. It is not a licensure or certification endorsement. Again, valuable training, but not, I think, the complete answer to this question in the future. Next slide. So what's the next step for EMS? Moving on a little bit, and Doug touched on this, should a degree be required for paramedic certification? That is a question that we've come up with in Virginia, and if you look at national organizations, this has been batted around for several years now, but I think that the discussion is becoming a bit more intense, if you will. Next slide. So this is from EMS Agenda 2050. One of their quotes, one might see this as a large network of trained emergency medical responders and emergency medical technicians with the basic tools and training to stabilize an incident, supported by degreed paramedics with more extensive education, equipping them to work hand in hand with other medical professionals, including EMS physicians. Next slide. This was also addressed in the discussion in the National Scope of Practice model. There was quite a bit of discussion, but in the end, they decided that the answer to that question was beyond the scope of that project. Next slide. As Doug pointed out, as paramedics start to move into, and paramedicine starts to move into more complex more integrated roles in the healthcare system, how do we keep up with the big house of medicine? He mentioned people like respiratory therapists, nurses, physical therapists now are being pushed toward doctoral degrees in PT. So what might the pros be for degree programs for EMS? And when I say degrees, I'm not necessarily talking about 4-year degrees, but 2-year degrees or associate's arts degrees as well. Well, again, there's this relationship with the big house of medicine. Paramedicine does a lot of really complex things. In the rest of the big house, people would be required to have a degree to execute or participate in that level of complexity. We would get the recognition of the complexity of the care, which people have been looking for in paramedicine for a long time. Hopefully, we would develop some enhanced career paths, and it might be a roadway to enhanced compensation for paramedics. Next slide. What are the cons? Well, it takes time to get a 2-year, 4-year degree, typically longer and more effort than it would be required just to get the certification. In Virginia, about 60 to 80% of the people who enroll in a paramedic course at this point in time are only interested in the certification. They are not enrolling in the paramedic course as part of an AA or BA program. So they're not looking for the degree primarily. The cost, it increases the cost of education, and people have concerns about that. Are we going to limit the pool of interested candidates if we make it more expensive to get that paramedic certification? And on an individual basis, what's your return on investment? College costs are increasing faster than inflation, or salaries for that matter. In general, as state support of secondary education or tertiary education starts to decrease. And then what's the benefit of a college degree generally? Many people with college degrees, bachelor's degrees, are having challenges in the workplace, finding a job that they felt really justifies their 4 years of investment in a college degree. I wish I had answers to all those questions. They're still out there. When I talk to young people who are interested in careers in fire EMS, I try to talk them into that degree option. You know, think about going someplace where you can get a 2 to 4 year degree in fire science or fire engineering, get your paramedic while you're doing that, and you'll be able to work anywhere. And it really prepares you also for a leadership position in our profession as we move along. Next slide. Coronavirus. I could probably just put that picture up there and not even say the word, and I think everybody would recognize it by now. So the question I had were, what are some lessons we've learned from COVID and the coronavirus that might stick once this pandemic has sort of tapered off? Next slide. I mean, how used to this scenario are we? And this has become commonplace now. This is what we look like when we go into work in the ED or we start our shift at the firehouse or the rescue squad now. Would we have thought this 8 months ago? No, but that's the reality now. Next slide. I talked to a friend who was going to fly out to, I can't remember if it was Colorado or Montana now, and they were concerned about the second hop on their flight, and they were going to have to wear a mask in the airplane for 3 hours. And they really weren't sure whether they were going to be able to do that or not. And I reassured them 3 hours is plenty doable. You know, try wearing a N95 mask and a face shield for 10 or 12 hours over the course of your shift. You can handle 3 hours in a surgical mask. So we talked about some of this in previous planning. You know, we spent a lot of time working on pan flu H1N1, brought some interesting questions forward, certainly opened my eyes to a lot of the realities of pandemic planning, but it didn't really materialize. And I put a qualifier in there yet, because we may face more severe epidemics of influenza yet. And then, of course, Ebola virus disease. Really scary disease. If you get it, you're going to get really sick. But there essentially wasn't any EVD in the United States. There were a handful of cases. But a lot of effort put out there and a lot of reinforcement. I used to talk about Ebola fatigue. You know, how often could we beat our providers with this when it actually wasn't a reality to most people in the United States? Well, that certainly wasn't the case with COVID. COVID is out there. It is essentially everywhere. We have to realize that virtually any patient that we come in contact with in EMS or the emergency department could be COVID positive, whether they are symptomatic or not. Next slide. One of our early concerns was, of course, workforce preservation and protection. You know, early on when I talked to my agencies and some of our regional planning about COVID, I pointed out that we may know people who get very sick from COVID, and we may even know people in our workforce that die from COVID. Luckily, that hasn't become the case, at least in the systems that I work with. We've done a pretty good job of keeping people safe. I don't think that we can back off in any way from what we're doing, but we can feel a little bit reassured that if we're careful and we really apply ourselves, we can keep ourselves and each other relatively safe. A lot of questions about the availability of PPE in the early phases of this, and that was an issue in some of the hardest hit areas. What was the right PPE? There were a lot of questions about what to use and when to use it. Would the PPE work? Was it going to be adequate? One of the questions that we came up with, not only in EMS but also in the hospital systems, is how do we get people to be safe when they're not at work? How do we get people to preserve their availability for their primary job? So is there a way to, or should we be limiting individual freedoms? What do people do when they're not at work? What do people do when they are at home? Are they observing all of their cautions outside of work? Are they traveling? Still open questions, I think. Next slide. Medical education was difficult with COVID. How do we continue our training programs? So limited classroom opportunities. We couldn't get large groups of people together anymore. Limited or no clinical experiences. There was a period of about 3 or 4 months in our academic medical center where we had interns and residents, but we had no medical students and we had no EMS providers rotating through the emergency department. Is there a question about whether we are turning out a different kind of student during this period of time? Are they as well prepared for release at their agency as they used to be? And I'm not sure that I've got a question to that. It certainly has resulted in increased attention to agency level credentialing. What happens when your new card-carrying paramedic or EMT gets to the agency? And what we have cautioned the agencies to is that they've really got to pay a lot more attention to that field preception, that field certification or credentialing process. We now have provisional certification for the first time from National Registry, recognizing that there were providers who had some challenges in taking the cognitive examination because many of the test centers were not open, but were not able to do a psychomotor examination. And they'll be expected to complete their certification later once the pandemic relaxes. But that's the first time we've dealt with that, with students that have come out with incomplete education. Next slide. How did public perceptions of EMS change? Where did all the emergencies go? We just are finishing up a project here in Virginia where we looked at our state database to see if the anecdotes about what happened with EMS held up under scrutiny. So many systems noticed approximately 40% decrease in their EMS calls. Well, where did all the emergencies go? Some of the shelter at home, stay at home measures might have limited, for example, trauma. There were many less vehicles on the road. People were not commuting to work. There were a lot of recreational opportunities that people didn't participate in. But our conventional wisdom was that the medical emergencies really shouldn't have changed very much, and might even have increased because people didn't have such good access to primary care. They were doing more video interactions with their physicians. Appointments were harder to get. Preventative health care appointments were harder to get. Did people decide that they didn't need or want an ambulance? And might that be a mindset that persists? Some of the reticence to call was probably out of fear of exposure to COVID, but was there a little bit more rational decision making there? You know, maybe I can get this taken care of without activating the 911 system. So did it change the threshold for calling 911? I'm not sure, and I think the time is going to tell. But there may have been some changes in behavior out there that might be beneficial moving forward. Next slide. I think that people are a lot more comfortable now with alternate transport destinations. We didn't have to implement all the plans that we drafted in you know, my little area of Central Virginia, but people became much more comfortable with alternate care facilities. And I think that that is going to persist in the system. Not everybody has got to go to an emergency department, and there are many cases where they can be cared for better or more efficiently somewhere else. Alternate dispatch and response strategies. We had drafts of stay-at-home policies where the crew would evaluate the patient and recommend that they stay at home, and what we called leave-at-home policies, where unless the patient met some clinical criteria, we would not transport if things got to that point. Again, in my little world, if you will, we didn't have to implement those policies, but we definitely had them on the shelf ready to go if we needed. And that was an eye-opener to people who were trained to always consider a dispatch to be a transport and a transport to the emergency department. And I think that we've been successful in changing people's outlook on that. Next slide. And Doug followed this or covered this as well. Many of the challenges and questions that came up with hospital system and regional planning were just a perfect fit for community paramedicine. Going out into the field, making these stay-at-home, leave-at-home decisions, perfect for paramedicine. Follow-up visits, if we do leave somebody at home, who's going to check on them? The availability of telehealth at the hospital and the clinic level was limited. Perfect opportunities there. What about testing strategies, both out in the community as well as at high-risk patient populations? Interface with high-risk populations and the use of community paramedics in strike teams, for example, adult care facilities. All of these are just perfect opportunities for community paramedicine, and I think open people's eyes, particularly in hospitals and hospital systems, to how community paramedicine might help out. Next slide. All right, the last thing I was going to touch on real briefly was the future of volunteer EMS. So Virginia has a very long history of volunteer EMS, very strong history. The back picture there was from the Roanoke Life-Saving Crew, which was generally considered the first volunteer EMS agency in the country. Lynchburg followed not long thereafter. When I started working with EMS in Central Virginia 30 years ago, the only paying position for a paramedic was with the flight program at the University of Virginia. Every other agency in the area, and there were about 35, 36 agencies, were completely volunteer. And in the 2020, almost all of those volunteer agencies are supplemented to a greater or lesser extent by career providers. Next slide. So what are some of the challenges? Well, the time required for certification and recertification. As we have tried to move the profession forward, we have required more from our providers. We have required more from their training programs. And that can be difficult for volunteers to participate in. People have different opinions about the time available to volunteer. Some people feel that that's not so much of a limiting factor. Others feel that it's a real limitation. People are working harder, they've got more things to do, their ability to volunteer is limited. How do they maintain skills? Not only is it time consuming to bring them in and do skills maintenance and skills verification, but as our credentialing has moved further and our skills have moved further, interventions have moved farther along. If you're only running one shift a week, how do you keep your skills up as opposed to doing it for 40 or 50 hours a week? That's a real challenge for people. Next slide. Well, so how can we help out? One, we've got to be collaborative. We've got to be flexible in the design of what I call hybrid EMS systems, where you've got volunteer and career providers working together to provide care and have a really strong and robust system. We've got to figure out some way to financially support the volunteers and their agencies. The volunteers have always provided a huge value to the area that they volunteer in, by not having that jurisdiction need to pay providers. But we got to try to figure out ways to support them in other ways. Reasonable training goals. Is paramedic certification a reasonable goal anymore for most volunteers? And it's not that a volunteer agency wouldn't take a card carrying paramedic, but it's very difficult now for a volunteer to move on to paramedic certification, particularly if it's a volunteer career that they're embarking on. Does advanced EMT offer the greatest benefit for the investment in most volunteer agencies? And again, we need to encourage flexibility in certification and CE scheduling. We are doing a lot more online and distance learning now, which I think makes it easier for volunteers to participate in that certification and CE training. Next slide. All right, I think that's it. Hannah, thank you very much. Sorry that didn't work out exactly as planned, and I will turn things back over to Kevin.
Super duper. Thanks, George. That's greatly appreciated. I'm going to push ahead into the last session, and then we'll hopefully have time at the end for some discussion as well as questions. Hannah, I think I've shared my screen. You see a presentation there?
Yeah, it looks like you're just showing us the GoToWebinar page. There it is. Perfect.
So do you have the first slide there?
Yeah, it looks great.
Okay, super. Thanks. Well, thanks, Doug and George. I'm going to attack a couple of things sort of around what they have just discussed. As I said earlier, my areas of interest are rural EMS and community paramedicine, among others. And throughout everything I do, ever since about 2001, I've been working as the communications technology advisor for NASEMSO and some other associations. And technology's always been of interest to me. And so when we start talking about telehealth and telemedicine, the concept of teleparamedicine has come up because I fully agree with Doug and George on the term paramedicine for what we do in general. And so I think there's a specific term to be attached to what we do with the technology we have, and I simply call that teleparamedicine. It goes beyond what we think of as telemedicine, with one practitioner talking to another practitioner, talking to a patient, but goes also into how we use technology to do things like use drones or use portable ultrasound or use health monitors in making decisions from the point of triage, from the point of 911 call and triage to delivery of resources to a scene, to treating at home or transporting someplace, whether it's the ED or an alternate destination. In my love of technology, I always am looking out for the best new thing. 2005, around then, I encountered in England the paramedic on the best motorcycle. When I brought that shot back to the United States, turned a whole lot of paramedics on to what a really cool thing being a paramedic could be. Just this past week, the other slides hit the air with the announcement of Lake District EMS playing with jetpacks to get a paramedic up a mountain to somebody who is stuck and unable to be brought down in a matter of accessing the patient in 90 seconds instead of 30 minutes traversing up a mountain. And so jetpacks is something actually I've thought of before in terms of being able to get a medic around where there are roads. The roadway structure doesn't allow a medic to get to an emergency very fast, and perhaps up and over a hill. The medic could get to the patient faster. But of course, we know what will happen if we bring this technology to the United States. And in fact, this was a story this past week about a jetpack getting in the way of an aircraft. So technology is good when it works, when it's applied appropriately. I'd like to continue in that vein, sort of looking at just generally an example of car crashes and technology, where we're going to go. One of the issues that we have, particularly in rural settings with car crashes, which tend to be high injury or fatality because of high speeds, is even knowing that a crash occurred. And there are a variety of technologies, and OnStar is one, and I'll talk a bit more about that in a second. But another one that's thought of is cell phones that are able to fly off a seat in a car crash and detect that and then dial 911, which in my case, that would be a really bad thing, because my cell phone flies all sorts of places on a daily basis, and I'd be forever calling 911. But when we think about learning that there is an emergency, the booming, blossoming technology of alerting from health monitors in your Apple Watch, which now detects arrhythmias and can set a sequence going where it alerts you, and then if you don't do anything, it'll alert somebody you care about, and if it doesn't do anything, it'll alert somebody else, and eventually 911 will be called. There are a variety of considerations to be made here. In Maine, where I live, the average delay in discovering a car crash in the rural areas of Maine used to be around 16 minutes. I think that's probably improved now, but it's still a consideration. And once that happens, our ability to get information about patients on the scene, get information about their medical background so we can treat them more effectively, has been something we thought about for many years, and is in fact some 10 or 15 years ago in Indianapolis, the ability for a medic on the scene in real time to access a health information exchange and get patient information was made available. And in the most recent National EMS Assessment 2020, we discovered that a lot of states, more so than we would have thought, certainly not a majority, but in the 10% to 15, 20%, depending on which technology, is enabling these kinds of technologies to allow EMS access in real time on the scene. And what that demands is that once that cell phone flies off the seat, or the Apple Watch goes off, or the health monitor goes off, we have to establish priority bandwidth through FirstNet or some other access. We have the issue of making sure that whoever is accessing that has verified their credentials to access it, and then getting a priority network, broadband network, established immediately so that medical records can then download with any kinds of medical alerts that may accompany them, and things like allergies and medications can show up at the ambulance in a matter of a minute or so, based in this particular example only on the fact that that cell phone attached to a person who had all of these records. In another case with devices, advanced automatic crash notification devices like OnStar, which trigger from the car, the ability to have an OnStar type bolus of data sent to, ideally, and it doesn't happen today, and this is an issue, It goes to a call center, an OnStar or other call center, and then eventually gets down to my phone in the ambulance. But if it were able to get to my phone immediately, I would know about that car crash taking 15 minutes or so off the call. And with these types of advanced automatic crash notification systems, being able to take the physics of the crash, which are measured and sent in that bolus of data, but also to do some analytics on it and estimate a probability of severe injury in that crash, allows for advanced protocols to be set up for dispatching things like helicopters or other equipment to that scene. So not only do you know that the crash has occurred maybe 15 minutes ahead of what we normally would, rather than having to drive half an hour out to the rural scene to determine that it really is a bad crash and you need the helicopter or extrication or whatever can be dispatched a half hour earlier. So those are some things that are in our future, if not there. And when we go out to that car crash, wouldn't it be cool if we could launch a drone out ahead of us so that we could get some feedback, video feedback of the scene and know whether there's a patient crawling out of that car into the woods that we otherwise wouldn't have been known about, or that there are smoke or liquids coming out of that crash car that we have to adjust our approach to the scene based on. And speaking of drones, other things in our future are being able to get medications sent ahead of an ambulance to a scene where an injection may be life-saving by a first responder on the scene. We have seen a number of instances this summer of drones being used to spot sharks in swimming areas off our coasts and get people out of the water, get lifeguards to get people out of the water in time. And then there's the AED being delivered by drone as an example. That's happening now, soon, if not now, in Reno, and is happening soon in Manatee County, Florida. The only hang up there is getting the ability to send a drone beyond the line of sight of the operator so that it can go all the way to a scene and deliver care. At the scene of the car crash, rather than hopping out and grabbing a bunch of stuff and then taking 6 to 10 minutes or so to assess the scene, assess the patient, triage patients, provide a little bit of care, contact medical direction as need be, which is probably a 10-minute space. We jump out of the ambulance and put on our throat mic so that we can start speaking our medical notes into a voice-to-text translation and put that into a database. We have a video on our uniform or on our glasses, so we can take video when we need to and put that into a database and begin to collect vitals, streaming those into yet another database, so that when we get to the patient side, we can use yet another device, a standoff vital signs monitor, to determine whether the patient is viable and we should continue care and assessment and care there. If we choose to do that, then we place a Band-Aid like patient monitor being used in facilities today, not in the field yet that I'm aware of, that would stream patient vitals into that database. The monitors are getting smaller and smaller, and our use of monitors is going to drastically change from carrying a big 12-lead capable ECG everywhere we go. And on the other end, once we have put our video into one database and our medical notes into another database and our vital signs into yet another database streaming, and we get the information down from the Health Information Exchange and put that in a fourth database, then the medical direction colleague in the hospital or the air medical colleague who will be coming to the scene can immediately establish a connection and knowledge of that patient that they're going to be helping us deal with. And that can happen. We've tested this, and actually doing the steps that I've described can happen in a matter of 90 seconds or so, rather than that 6 to 10 minutes. Moving on from car crashes to other applications of teleparamedicine, telehealth. as George and Doug have mentioned, our COVID experience has led to a number of new telehealth modalities that we have been playing with. But even before that happened, Project Ethan in Houston utilized telehealth tablets so that when a 911 crew got on the scene, made an assessment that this patient probably did not need to go to the emergency department, they could connect with a doctor 24/7 and have an intervention there and end up treating in place with the capabilities that they had, or to have a patient go to an alternate destination. I know that George and Doug both have some examples of other teleparamedicine examples. George, can you tell us about the field neuro assessment, stroke assessment that you're doing in Virginia? Just need to unmute yourself. George? Okay, let's move on. Doug, how about the telehealth units you're developing?
There we go.
Oh,
Can you hear me now?
I can hear you now.
I'm sorry. Maybe it's because I'm on a Mac, but this thing is just not working very smoothly. So, yeah, what we've had in Virginia, I should say in our local area, was a project that we called iTreat. And what iTreat did was put together a relatively inexpensive package. It was iPad based, and we used a modem. And we actually got some FirstNet SIM cards to use in the project, where the medic in the back of the unit would get in touch with a stroke neurologist, a card-carrying stroke neurologist in real time, and do a neurologic exam with the stroke neurologist in the back of the ambulance. And what they found was that the stroke neurologist was able to do a very accurate exam that agreed very well with the ER stroke assessment that was done after the patient's arrival at the stroke center. So phase one was more of a feasibility study where we looked at the technology and the assessment. And phase two, which we're about to move into, is going to actually start calling our stroke alerts from the field based on that interaction between the stroke neurologist and the medic in the back of the unit. So we're pretty enthused about this, but it's a really good example of how technology, bandwidth and priority, the FirstNet hallmarks, can let our medics interface with physicians to make, real-time, complex patient care decisions.
Cool. Doug, about your experience
Sure,
coming
Kevin.
up?
And Kevin, were you able to put that slide in, or those two slides, or no?
I'm sorry, I didn't get them in time.
Okay, that's no problem. So, the first slide I sent was basically of a communication center, and I was Kevin asked for a slide to sort of put in as a placeholder of our communication center. And actually, the slide that I sent, because of COVID, most of our people at the communication center and our system triage officer area, that sort of thing, are working from home right now. So I sent a picture from what was going on in 2013, when a number of us, including some of those that are still state officials, toured the EMS agency in Israel. And, one of the things we saw at the time was a person sitting at a desk who saw the telemetry, the vital signs, everything from every EMS monitor that was hooked up to a patient across the country at a single desk, so that when they called in, they were able to immediately see the patient's heart rhythm and vitals and that sort of thing, and talk about that patient. I think that's our vision for where we're going locally with my system. But right now, what we are doing is, by the end of this month, we are training all of our paramedics, and we're putting 19 telehealth units into 19 of our ALS 911, or actually ALS and BLS 911 responding ambulances. So the case that I gave the example of earlier, it was fortunate that I was able to swing out to that scene and do that intervention and set up the antibiotics and things for that woman. But that's certainly something that our BLS ambulance in the future ought to be able to do through telehealth. We have a system triage officer who is an emergency physician who's also an recognized medical command physician in the state of Pennsylvania. And that individual sits with our health systems transfer center. So at their disposal, they are sitting with our EMS communication center, our transfer center nurses that are arranging beds, direct admissions, all that sort of thing, and our tele nurses that are giving advice to callers that are calling in, trying to talk to a telenurse. All of them sit and integrate together. And now since COVID, they're sitting at home, but integrating together. And that individual is an emergency physician whose sole responsibility is to coordinate all this, and already does this for our MIH group. When our MIH group is out, if they feel that telehealth will help, and that's only a minority of their cases where telehealth helps, they can connect. And frequently our system triage officer will recognize something that needs inpatient care, and they bypass the emergency department by talking to an admitting doctor, getting a bed from the placement nurse assigned, and then just doing a direct admission for some of our patients. For others, they direct them to the emergency department, and for others, they arrange things like, you know, the IV care, diuresis, IV fluids, antibiotics by our MIH group. We're expanding that this month to 19 of our 911 responding ambulances also. So I think that's the, that's the direction that things are going. We've taken a little different approach than George described with the telestroke. My personal feeling is that, we can't expect to interrupt and send an ECG to the cardiologist that does STEMIs and get a neurologist on to do a stroke exam and, integrate with lots of other physicians. We probably need to have that ability for things that are very specific to their expertise. But, the way we view it, emergency physicians are very familiar with EMS and familiar with the examination of all these emergency cases. And so we do all of ours through an emergency physician as the central point. And I think that is a model that serves things well.
Thanks, Doug. Thanks, George. Moving on. I'm going to skip a couple of these and move into another area because we already talked about centers, and I was going to mention that, but I think Doug covered that pretty well. But also moving on with a sort of an issue that's near and dear to my heart, which is the rural EMS dilemma between the volunteer evolution, which is happening that George described, and the depletion of health resources in the smallest towns, the furthest away from major health facilities. EMS is obviously increasingly being called upon to do more in those towns. And a lot of that is a combination of trying to do some things that can be done for treatment in place, and some things that still inevitably take the ambulance. In fact, more frequently take the ambulance out of town to places further than ever as hospitals close in those areas, and depleting all resources in those towns for periods of time. So I picture a kind of MIH that Doug was describing around the 1 or 2 ambulances that are in town, with the community paramedic being a much even more robust practitioner than we think of today as a community paramedic, with the capability of things like portable ultrasound that may be remotely monitored and interpreted, or locally if that capability is there for that practitioner, and other devices within the ambulance. Maybe not a CT unit, but maybe something of that sort. Certainly point of care labs, as Doug mentioned, but other imaging and diagnostics. Essentially make the mobile integrated healthcare capability in that town very robust. So a majority of the stuff that is needed in that town can be managed by the community paramedic in partnership with what other healthcare practitioners still exist locally, so that the community paramedic is filling in the gaps where needs exist. But at times, there will be needs to go beyond the treatment in place and get a patient to a hospital. And, it may be a fracture. It may be something that cannot be managed, but is not necessarily life-threatening. And I think that in that time, we look ahead to the driverless ambulance, so that we're not taking all of our resources out of town, that perhaps a first responder trained or basic EMT trained individual practitioner could take a patient in a driverless ambulance without lights and sirens to a distant hospital and get the patient there safely. And that would be sort of a majority of transports that might be done. But in those cases where there is a patient that whose stability is uncertain, that another alternative to a very expensive helicopter system for those types of things that we may consider in the future is expansion of the drones that I just mentioned. A drone big enough to put a patient in, a drone that's equipped with an eICU capability that are being used all over the country now to monitor that patient and perhaps intervene in when the patient's needs so dictate, whether it's remote defibrillation or turning up drips or starting certain meds in a multi-med intravenous setup for the 15 minutes that drone takes to get to the trauma center that otherwise might have been a much longer transport, taking the ambulance and the community paramedic and the EMT out of town for 3 or 4 hours. So I think these are very exciting times. And I think we have a lot of really neat stuff in our future, whether it looks like this or elsewise. I'd like to bring us all back up for a couple of minutes of discussion. If we can stop sharing my screen. And there we go. So, Doug, comments? Any kind of follow-up comments you might have?
Well, I think, my follow-up is that I think that all of this stuff is very, very exciting. And I think that there are some very simple things we can do with telehealth that is becoming more and more like what's already available in people's communities and homes with Wi-Fi connections and relatively inexpensive equipment that can dramatically change the way we give healthcare through EMS. And I think it goes all the way up to very sort of expensive, but in the long run, high-end solutions. Bottom line is, I think that this is a very exciting time for EMS. And as I said at the beginning, we've been doing some things almost identically since 1973's EMS Systems Act. And I think, the things that are coming along with changes in revenue and reimbursement and the way we look at EMS really stand to change what we have traditionally viewed as what we do with EMS. And I would like to start calling it something else.
Yeah, and I would second that. I think one of the more exciting things recently has been the opportunity to kind of showcase paramedicine and have other people realize outside of emergency medicine and EMS how skilled our providers are, how skilled they are in the out of hospital arena. They're comfortable there, they're experienced there, they know how to handle situations out in the world, and help people realize that they're a really valuable part of the healthcare system. And we talked about COVID and some of those challenges that we've had, and it was fun to be able to point out to people that they had a lot of questions that they didn't have answers for, and EMS and paramedicine can answer a lot of those questions, and they're kind of ready to go with it. Yeah.
Hey, Kevin, I've unmuted the lines. We're starting to see some attrition due to the time, but if you're on the call and you'd like to enter a comment or talk to the panelists, you can try to unmute your microphone and join the discussion.
While we're waiting, George, I couldn't agree more. I think that COVID has had people within health systems pointing to EMS, whether it's EMS physicians, because they see what they bring to sort of an incident command, emergency preparedness kind of structure for health systems, to EMS providers when it's, hey, we can get a paramedic to go out to this personal care home and, test everybody in the morning for COVID, and it's something that they're very easy to take as an assignment and take the response, where other parts of healthcare, it can be a major lift to try to get somebody to go and do something like that. So I think we are being recognized. We just have to get the pay for the individuals and the professionalism within the House of Medicine for the individuals to line up with what people are now seeing that they can do.
In my experience, it is really amazing. Once community paramedicine takes hold in a community, it proves itself through one service or another that it is delivered, that how fast other healthcare providers suddenly realize that paramedics can do that and can fulfill that role. So maybe they could do, and then suddenly start suggesting A, B, C, D, E, F. And those programs start to evolve very rapidly. But it takes so much time to get to the point where that recognition happens, because saying community paramedicine at this point is confounded by the fact that nobody knows what paramedicine is, what we can do, or who we are. And so I think your comments about the profession are just central to what we need to concentrate on in the future. Anybody else have questions or comments?
I was talking to our residents, and one of the, I'll just fill in here, and if somebody's got a question, please interrupt. But one of the skill sets that emergency medicine physicians bring to the table is the ability to take an unsettled situation and quickly kind of suss it out and come up with a plan. And not everybody in medicine shares that desire or that skill set. And when people were able to realize that paramedics were able to go out into the world outside the walls of the medical center and take an unsettled situation that involved a lot of different moving parts and make sense of it, and settle it and make interventions for the patients. That was a real eye-opener for a lot of people. They're just not used to working in the real world outside of the walls of the medical center.
So Kathy, do we have anybody else out in the audience have any questions or comments?
Nope, I don't. I'm not seeing any. I've had a couple comments about what a great presentation this was, and expressing their appreciation to each and every one of you. I'm still looking, but I don't see anybody typing in the box.
Sounds like we call it a program.
I think that I don't see any. Let me just check for any raised hands. I think we're good, Kevin and George and Doug. Thank you so much for your expertise today. It was a very enjoyable program. The NASEMSO members that are on the line, we are going to be leaving GoToWebinar, and you should see the login information for the abbreviated annual business meeting in the agenda that's posted under handouts. And we sincerely appreciate everyone's engagement this week, and look forward to the time when we can get together in the same room at the same time again soon.
All right, thank you. And thank you, Kevin, and thank you, Doug.
Thanks, everybody.
Thanks, guys.
Bye-bye then.
Bye-bye.